Welcome to the Understanding Meaningful Use conference call. My name is Anna and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question and answer session. I will now turn the call over to Daniel Chipping. Daniel Chipping, you may begin.
Hello, everybody. Welcome. Thank you for attending our webinar today. I do want to acknowledge we've had a little bit of a hiccup starting off. There was some confusion as to the registration process. So the initial registration was with Health Insight. You received a confirmation email from Health Insight. If anybody's on the phone who hasn't been able to get in online, please go to your email from David Cook, and the subject of the email is "Thank you for registering for webinar." And in that email, you'll click on the webinar URL. And once you've clicked on that, you'll need to register again inside of WebEx to be able to view the online portion of the webinar. So I just want to let you know we've got 63 people online. I know there are more of you on the phone, so feel free to use the chat if you've got any questions about logging in. We've got people here who will be able to help guide you through with that. So in the meantime, just listen and enjoy, and we hope you all get on successfully. And with that, we'll go ahead and start the webinar. So again, thank you all for being here. I wanted to introduce to you that this is a multi-state webinar. Health Insight and Acumenture Health we're spread across Utah, Nevada, New Mexico, and Acumenture Health in Oregon. And so we have participants from across all 4 states, and we've even got a couple people who snuck in from Arizona and North Carolina. So welcome to all of you. We appreciate you being here. As I mentioned a minute ago, feel free to use the chat window to ask questions, to communicate with each other. I've got team members who are ready to answer your questions in the chat function while I'm talking, so feel free to have a conversation on the side. And I'm going to go ahead and introduce myself, and then I'll turn it over to Rini and let her introduce herself for a minute. As you heard, my name is Daniel Chipping. I'm a project manager here at Health Insight. I've been helping clinics meet the requirements for meaningful use for the last 3 years. Before I came to Health Insight, I was a clinic manager, so I know the shoes many of you sit in. I've experienced it before, and I appreciate your challenges. And with that, I'll go ahead and turn it over to Rini and let her introduce herself.
Good afternoon. I'm a nurse who has worked in hospitals and outpatient clinics in a variety of settings and positions. I started working at Health Insight New Mexico in July of 2010, just in time for the start of Meaningful Use. During these 5 years, I really enjoyed working with practices and hospitals across New Mexico with electronic health records and the Meaningful Use program. I see quite a few familiar people signed on today. Thank you all for being here.
Okay, thank you, Rini. So I want to make one acknowledgement as well before I get going, and it's a pre-apology to all the hospital people. Because of my affinity or connection to clinics and mostly working with clinics, sometimes I might say provider or clinic instead of facility or practice manager or administrator. So if at any point I talk from a clinic perspective, please know that pretty much all of this applies to you as well. I do recognize that we have a lot of hospital people on the line, and so I want you to know that the webinar has been produced with you in mind, so hopefully don't get offended if I just mention clinics or providers too frequently, and I'll try not to do that, but that's just a just-in-case comment. So we're going to give you a quick overview of the objectives. The Meaningful Use vision is the first thing I'm going to talk about. Why do we have it, and what's its purpose in the country right now? The second part will be diving into difficult Stage 2 measures. The third part will be understanding proposed changes. Rini is going to talk about understanding the proposed changes that have been recommended for Stage 1 and Stage 2. Then Rini will talk about the introduction to Stage 3. And I will finish off with the future of meaningful use. And I just want to mention that, again, the 2 sections that Rini is going to talk about are just proposed changes. And even though we're going to go into it in detail, they're just recommendations right now, and they're not final rules, so we can't take it with too seriously at this point. So the first thing we'd like to do on webinars is start off with audience participation. So you see the poll up in front of you on the slide. You'll see a window pop up on the WebEx, and go ahead and click on the answer that fits you or your practice or your hospital or your providers. Are you planning on attesting for meaningful use in 2015? So the reason we put this question up here is because it directly applies to where meaningful use is at right now. We recognize that it's very challenging, and soon there are going to be changes coming. And so go ahead and click, and then we've got 4 seconds left, and we'll see some results here. And if anybody clicked at the last second, it might take another few seconds for us to see the results. So should be up shortly here. And I'd like to just comment, there are the results. So we've got 57 out of 108 participants who, and by the way, our participant numbers continue to climb, so I'm glad everybody's getting on successfully. So it looks like we have most people are planning to attest for meaningful use. We have one that's not, and a few unsure. So hopefully what we talked about today will help you decide whether or not you continue with meaningful use as we move forward. So the next part of this is the vision of meaningful use. Why is meaningful use here, and what's happening with it? And I want everybody to think about, what do we want health information technology to do to help the healthcare environment? How do we want it to help our patients? How do we want it to help providers in the system for delivering care? So stage 1 of meaningful use is really about one word, and it's called functionality. Stage 1 was about identifying the key things that we should be, the minimum level of functionality that we should have in our information technology. So with our vendors for EHRs, with our health information exchange, with communication. Stage 2 is about taking it to the next level and making it about processes and improving processes. And stage 3, it takes it to the end where we want it to be about outcomes for the patient. So the reason we wanted to just address this and talk about it today is we want you to keep the vision of where meaningful use and where healthcare is going. You need to just remember and think about the diabetic patients, the high-risk patients that you have in your practice that need a little bit of extra help. Imagine the clinical decision support rules, for example, that can notify a provider if a diabetic patient who hasn't been seen in 6 months or a year and they come in for a cough. Even though they're there for a cough, the provider can know that they need to be seen and have their A1C levels strong, or that there's extra communication that can happen between providers, and that the providers, specialists can know what's happened in the primary care office, and that hospitals or primary care docs can know what's happened in the hospital. So just keep in mind the vision that you have for where you want healthcare to be as we go through these struggles and challenges. Yes, it is difficult now. It will probably continue to be difficult, but we have to go through these difficult times to get to the end of what we want healthcare to look like. Having said that, let's jump to poll number 2. We're going to dive into which stage 2 measures are most difficult for you and your providers. Go ahead and click. The numbers reference the eligible provider requirements for meaningful use, so they might be numbered differently than for the critical or for the hospitals or critical access hospitals. So go ahead and click on the one measure that's most difficult for you. If there's a measure that is not listed here, click on Other and type it in the chat box. We'd love to see the discussion and which other measures are challenging for you. In meaningful use, we've done enough of this to kind of have an idea of what's challenging, so we narrowed it down to these 3, but I do recognize that there are others that will be challenging for you and your practice and facility. And let's see what the responses come in as. I think, okay. So surprisingly, I'm going to say that I'm surprised by this. I thought that summary of care may be a little more challenging for most, but it looks like the winner, or the loser maybe, is the patient portal view, download, and transmit information. So thank you for your responses. I think it's helpful for everybody to see that we're all having challenges with these things together, and it's not just only our own facility that has this challenge. So let's dive into the first one, difficult measure, core measure number 7 for eligible providers, which is to provide the patients the ability to view online, download, and transmit their information within 4 days of the information being available. So that could be the information from the notes after a visit, or information from a hospital stay in a discharge summary. It could also be information that comes in as lab results. So the key here is that 50% of the patients have to have access. Access in most cases for most vendors means that the patient has a login and a password to get into the web portal to view their information. Unfortunately, there are a few vendors who made the bar pretty high and called access the actual viewing, downloading, and transmitting, which makes it challenging for some practices. But hopefully for most, it's relatively easier in just getting the access shared with the patients. I recognize that one challenge in that, especially for internists and people with older populations, is that sometimes older patients have a harder time wanting to log into the internet, but there are ways around that, and one of them is I'm going to address talking about the next piece of this measure, which is viewing, downloading, and transmitting the data. So as a practice, you can actually help your patients do this. I know that providers and practices and hospitals don't like to be held accountable for what their patient does or does not do. And so what I've recommended and what we've found works best for most facilities that are able to meet this measure is that they help their patients actually log in somewhere in the check-in or check-out process, or maybe while they're waiting in a room. If someone can log in with the patient, show them around the portal a little bit, help them understand why they might want to use the portal, and then actually meet the measure for the patient while they're on site, then you can help get that 5%. Because it is a low percentage, you could actually look at your patient list every day and say, who are the 5% of patients that we want to specifically target? Maybe we'll go 6 or 7 in case a couple of them decline. And who are the patients that we're going to work with today to get logged into the portal so that we can meet this measure? The second piece, or the second measure that practices frequently have a challenge with is the security risk assessment. And we brought this up because the big challenge with this is it takes a lot of time. It's got a lot of technical wording, and I would venture to guess that the 3 out of the 115 that responded to this question and said it was most difficult, that there are probably more of you out there from our experience who think they've maybe done the risk assessment, and that if you had to rank your own confidence on whether you'd pass an audit, you might guess again, and you might say, well, let me step back and say that I'd want some more help with that. So the challenge with this measure is that a lot of facilities think that the vendor just does it for you. You know, my vendor takes care of our risk assessment for us. But that's not true. You got to just think about what a risk assessment covers. It could just be a simple questionnaire, but it needs to have aspects that talk about physical safeguards. These are things that your vendor does not do for you, like do you have a door lock on your server room? Technical safeguards, like where do you put your firewall? Is it on which side of an internet-facing device is it on? Some administrative safeguards, like password requirements. What length of passwords do you have? How frequently do they change? What policies and procedures do you have? So again, these are not done by the EHR vendor. You want to make sure that you give yourself sufficient time. You find a good tool that's going to give you good feedback so you know what you can improve upon. And I will just say that if you have any questions on this, Health Insight and Acumenture Health know where to direct you to find good people who can help you solve the risk assessment challenge. So the next measure we're going to talk about is core measure 15. The eligible provider who transitions a patient to another setting of care or a provider of care, and you need to provide a summary of care record for each transition of care or referral. Now, this is the transition of care. It's an outgoing transition of care, so you're sending somebody to a specialist or a hospital or to another provider, or they're moving out of the state and they need their records to go to another provider. So in this case, you create what's called a CCD, a continuity of care document, and I'm going to use that term more than summary of care just because it's a little quicker to say CCD. So for all the patients that are going out, more than 50% of them need to have that CCD document created. Gratefully, a lot of that can be on paper, at least for stage 2 as it exists right now. The challenge is when it comes to the second measure, which is more than 10% of those need to be electronic. The good part about that measure is that it's been recognized that it's oftentimes easier to send those through the same EHR. For example, anybody on eClinicalWorks, they have the provider-to-provider tool that allows you to do that. If you don't have somebody that you're referring to who has the same EHR as you still need to get 10% of them done electronically. Then they would kind of fit in with the third piece of this measure, which is send one electronically to a different EHR. And this is frequently where most practices have a little bit of a challenge. So I've got a couple slides that are going to introduce some topics to you. We wanted to keep it kind of high level. We're happy to go into more detail on this. If you call or have questions or want to send us emails, we can help you have more information to move forward with this. So the possible solutions to sending a test or to send the CCD document electronically are 1, through your electronic health record vendor, 2, through your health information exchange, and 3, through the test EHR that was built by CMS. So let's talk a little bit about each one of these separately. Your EHR vendor is likely set up as a direct trust vendor. What that means is that they are either a HISP themselves, an information service provider, health information service provider. You can think of a HISP like Gmail or Yahoo just for healthcare. And so your EHR is either the HISP themselves or they're contracted with a HISP. And so what you need to be able to use this is a direct address, a direct email address. So if it were my direct email address, it would say dchipping@directhealthinsight.org. So that's if Health Insight were a HISP or providing direct email addresses. And so when you have that direct address, then you use that account to email patient information, in this case the CCD, the summary of care record, to another provider who also has a direct address. So the ONC has provided a Q&A on direct, and that's the first link on this slide. The second link is Direct Trust 101. Direct Trust is a nonprofit organization that was built to support healthcare organizations becoming direct certified so that we could have this platform of communication. And so the third link is that it's a list of all the providers or all the entities that are accredited or are pending accreditation with Direct Trust, so you can see whether your EHR vendor is listed there with them. In fact, I just listed a couple as an example, definitely not a complete list, but you can see some names you recognize. Cerner, eClinical, Optum supports some of the HIEs. I know that Orion, another HIE vendor, is also accredited. What's interesting to me is the candidates who are not accredited. In Utah, the first one, Intermountain Health, is a very big player. And so many of the providers who want to refer to specialists or send a patient to a hospital, they're going to be in the Intermountain Healthcare system. Intermountain Healthcare is not accredited, and they don't have a provider directory, which is the list of providers and their direct email addresses. So it makes it challenging if you're only sending to Intermountain practices or hospitals. And the same is true for the U.S. Department of Veterans Affairs. So anybody who has veterans that are seen in their practice or hospital, if you're trying to send that patient to the VA and you want to send a CCD document to the VA, unfortunately you're not able to do it through direct quite yet. I know that they are working on it. They're close to being accredited. But that just gives you an idea. At least you know where to go to look at vendors and start asking people for their direct lists. The second way that you can help send an electronic CCD is through your HIE, the Health Information Exchange. Again, they also support Direct Trust or use Direct Trust as a platform. They also do what's called, listed as number 2, as a VPN, a virtual private network. So if you think of your doctors or your billing people who like to work from home, oftentimes they'll connect to the clinic server or the hospital server through a VPN, in which case, if you wanted to do that by yourself, you'd have to have a lot of VPN connections between your practice or your hospital and everybody else who you want to send information to. Rather than do that, you can have a VPN to the HIE, and the HIE has the VPNs with everybody else, and then the communication all flows through the HIE. A real good benefit of this is if you have a list of patients that you create a rule with your HIE, and you say, I want any information that comes in on any of these patients from any other source, and they'll send you messages and show you that that information is coming in. So then you could be sending the CCD document in, and it would be going automatically to the people who have an interest in that patient. The third way, query, this is for anybody who's familiar with NHAN or NQIN. It's the National Health Information Exchange Standards and Protocols. They've changed it into a healthy way. It's another method of the HIE has for sharing information. The fourth method is a master. I made up the word master for this because I think it's a good description of what happens. But if you have 10 organizations submitting a CCD into the Health Information Exchange, if you as a practice, as a provider, want to see all of that information, you don't want to see 10 CCD documents. You want to see it combined all into one. And so one master continuity of care document would be created. There's a little bit of a delay on this one, though, because each Health Information Exchange needs to be recognized or approved by the ONC, just like your EHR vendors have to be. So the HIEs will have to be certified to create that CCD document. And I know that some of them are working towards getting that certification. Finally, number 5 is specific to hospitals, but it's definitely one worth knowing about, and a great way for hospitals to meet the measure is by sending alerts. So when a patient is admitted or discharged from the hospital can send an alert through the HIE to the provider, to the primary care provider, or whoever needs to know the information about the patient who's being discharged. So again, like I said, it's a very brief overview about what an HIE can do to help you with electronic documents. I definitely recommend talking to each of your respective HIEs in your states. I know that Oregon has 4 of them, so find the one that works best for you guys. And, it's going to depend on your own technical functionality and capabilities in your location, as well as the technical and capabilities of the HIE and where they're at currently for which of these options will be most beneficial for you. If either the HIE or the EHR solutions don't work, then the third option is to use the CMS Test EHR, and you can see kind of a map that shows what the process is, but essentially you connect on the CMS website, you specify your EHR, you tell them where you're from, what EHR you're using, your certification number. They randomly assign you to a test EHR, and they give you instructions and help you walk through that process. That's all I'm really going to say about this one. But if you need to get to this step, I'd say definitely work with Health Insight or Acumenture Health to help you get through this process. So with that, I'm going to wrap up this section with another poll. There's 2 questions in one, so please answer both of them. We'd like to know how many of you actually have or know your direct email address, and if any of you know other providers' direct email addresses. This seems to be in talking with the HIEs across each of the states, this was universally the most common way that people are trying to use and trying to share CCD documents with other providers. So if we could get that poll question up, and then you can answer it as soon as you see that, and we'll find out kind of how many people actually know direct email addresses. While you're answering this, I think the most important key to recognize is that when you call somebody and ask them for their direct email address because you want to send information to someone, just think of them also calling you and asking for your address. The best way that we're going to be able to build this is by everybody working with your EHR vendor or your HIE and setting up your own direct email address. So just again, think of that as you consider where do we want the future of healthcare to look? What do we want it to look like? How do we want communication to work? Is it all somebody else's job, or do we have a part in building this to make it work how we want it to work? So should see results here shortly, and we can see how many. I'm guessing that there will be a lot of no's. That's just my guess from being out on the ground and talking and working with clinics and hospitals so far. But you may surprise me. We may have a different crowd. Okay, you surprised me. 56. That's more than I thought, so that's great. In fact, what I'd love is if the participants who answered yes to both of these questions, if you would share maybe in the chat box for everybody else who answered no, how did you get your direct address? How long did it take you to get your address? What EHR vendor or what HIF did you work with, and how did you get provider directories or lists of other providers so that you would know how to send a direct message to them? With that, I'm going to leave this topic and turn it over to Rini. Rini's going to talk about stage 1 and 2 proposed changes that are coming. And again, I've been talking about challenges as they exist now, and recognize that there may be some simplification and some things that are going to become easier in these proposals that Rini will be talking about. So, Rini, it's all yours. Let me give you the control of the slideshow, and you should be ready to go shortly. Okay.
Thank you, Daniel. Daniel talked about meeting measures as they are currently. Now I will review the proposed changes. I don't want to get too excited about them since they aren't final, but they certainly look more attainable and useful.
Click on your slide, Rini, with the button, and then use the page up and down.
Got it. The two notices of proposed rulemaking, or NPRM, were released by the Department of Health and Human Services, or HHS, and the Centers for Medicare and Medicaid Services, or CMS. The first proposed modification was released on March 30th, 2015, covers Stage 3, Electronic Health Record Incentive Program. The second proposed modification was released on April 15th of this year and covers modifications to Stage 1 and 2 meaningful use for 2015 through 2017. These proposals apply to those eligible professionals at EPs and eligible hospitals and critical access hospitals who can participate in the meaningful use EHR incentive program. I recognize that hospitals and critical access hospitals have differences, but since most of the meaningful use requirements are not different, I will use eligible hospitals to reflect both types collectively to make it easier when speaking. The public comment period for these proposals is over, and we expect the final rule to be released soon. Until it is released, every modification I mentioned today should be considered proposed only and subject to change until the final rule is published. These are the three overarching goals of the proposed modifications to meaningful use for 2015 to 2017 for eligible professionals and eligible hospitals. These modifications refocus the existing program to build towards the advanced use of electronic health records or EHR technology. These overlapping goals should lead the way to a long-term sustainable program. Goal 1 aligns Stages 1 and 2 objectives and measures more closely with the long-term proposals for Stage 3 and are meant to prepare everyone for Stage 3. Goal 2 is to synchronize and streamline reporting period objectives and measures to reduce the burden. Some measures were removed due to advancements in EHR function and provider performance in stages 1 and 2. The overall number of objectives are proposed to be reduced to focus on the advanced use of your EHR and to promote the use of best practices in the care of patients. The menu and core structures of stages 1 and 2 are merged into just core measures, which are mandatory if exclusions do not apply. Removed are reporting requirements which are redundant, duplicative, or topped out. Examples of goals removed are recording of vital signs and maintaining an active problem list. Goal 3 supports continued use of health information technology to improve outcomes of patients. Some examples of advanced use of health information technology are the Health Information Exchange, the HIE, and patient engagement. We will now look at a summary of changes for hospitals. For 2015 to 2017, the reporting period is proposed to move from calendar year to fiscal year. All will report on 8 objectives and 1 public health objective, where you'll have to meet 2 to 3 of the 6 options available. In 2015 only, the reporting period is proposed to be any continuous 90-day period from October 1st, 2014 to December 31st, 2015. Those in Stage 2 will attest to what is called the modified version of Stage 2 meaningful use. Those in Stage 1 will be allowed accommodations and exclusions to the modified version of Stage 2. This means there are allowances for alternate measures, exclusions, and or specifications for certain hospitals to accommodate these proposed changes. Today I will present a few of these. An important point for 2015 is for those scheduled to demonstrate Stage 1 in meaningful use in 2015, an exclusion for any retained Stage 2 measure where it's not a current equivalent Stage 1 measure could be made. An example of this is computerized provider order entry, CPOE for short. The Stage 2 CPOE objective includes measures for laboratory and radiology orders where Stage 1 does not have these measures. So eligible hospitals in Stage 1 for 2015 could claim an exclusion and would not be required to meet the laboratory and radiology measures. This exclusion would also apply to eligible professionals. For 2016 only, all eligible hospitals would attest to Stage 2 modified version of meaningful use. New participants can attest for any continuous 90-day period within the calendar year. Returning participants would have to use a full calendar year. For 2017 only, attestation would be for a full calendar year, except for those Medicaid hospitals demonstrating meaningful use for the first time. You will be able to either attest to either the modified version of Stage 2 or the full version of Stage 3. Now I want to talk about proposed changes for 2015 and 2017 for eligible professionals. For this time frame, there are 9 core objectives and 1 to 2 public health option measures which are chosen from 5 available. For 2015 only, all eligible professionals would be able to attest for any continuous 90-day period within the calendar year. Those in Stage 2 would do a modified version of meaningful use. Stage 1 allows for a modified version of Stage 2 with accommodations. Stage 1 accommodations allows for all eligible professionals who have already begun working towards meaningful use in 2015 to continue what you've been doing. There can be an accommodation to the modified version of Stage 2 meaningful use for Stage 1 eligible professionals if there is a lower threshold or other measured difference between Stages 1 and 2. In this case, those in Stage 1 can use the lower threshold. An example is for Stage 1, the threshold for electronic prescribing of medications is more than 40%. Stage 2 is more than 50%. You could elect to use the more than 40% threshold, which is lower. Another example is that both Stages 1 and 2 have the first part of the electronic access measure in common, which is more than 50% of patients are provided timely online access to view, download, or transmit their health information. This requirement would remain. Stage 2 also has a second part, which consists of one patient that's seen by the eligible professional, views, downloads, or transmit their health information to a third party. For Stage 1 in The second part of this measure would not be required and exclusion could be claimed. In 2016 only, new participants can attest for any continuous 90-day period within the calendar year. Everyone else would attest to a modified version of Stage 2. And then returning participants, again, must use the full calendar year. In 2017, all eligible professionals would have to use a full calendar year and could attest to either the modified version of Stage 2 or the full version of Stage 3. These are the measures which compose the modified version of Stage 2. The alternate measures and accommodations for those in Stage 1 and exclusions are too lengthy to include here. All the details can be found in the proposal. The middle column refers to eligible professionals, and the right column applies to eligible hospitals. Some of the significant proposed modifications are highlighted in red. One highlight is that for eligible hospitals, electronic prescribing has moved from a menu set item to a core item. If you are scheduled to do Stage 1 in 2015, this could be claimed as another exclusion since there is not an equivalent measure in Stage 1. Another highlight is that the Patient Electronic Access Measure 2 for both eligible professionals and eligible hospitals changes from more than 5% of patients must view, download, or transmit their health information to equal or greater than one patient seen by the provider or discharged from the hospital performs these actions. A wide variance of results on the Patient Electronic Access Measure and secure messaging showed that more time was needed to move the needle forward and change patient behavior. Medication reconciliation does not change. For summary of care transitions, previous versions of Meaningful Use were very specific as to the method of electronic submission. In the proposed modified Stage 2 version, more than 10% of the summaries of care must be electronically transmitted, but now you would have the flexibility to determine what electronic means. Secure electronic messaging would change from a percentage-based measure to a yes-no measure. So in order to meet this measure, the capability for patients to send and receive a secure electronic message would need to be fully enabled during the entire reporting period. Protecting health information would remain the same. The security risk analysis must be either conducted or reviewed for each reporting period. There is no change to the patient-specific education measures. Public health requirements would be consolidated into a single objective with multiple measure options. This follows the proposed Stage 3 public health requirements. Under this one public health objective, there are 5 to 6 measures you can choose from. Eligible professionals would have to meet one of 5 measures for Stage 1, and for Stage 2, would have to meet 2 of the 5 measures. For eligible hospitals, you would have to meet 2 of the 6 measures for Stage 1, and 3 of the 6 measures for Stage 2. A significant change is that reporting to different public health registries and clinical data registries can be counted more than once. Another significant change is that the proposed language reads, is in active engagement with one of these reporting agencies to submit and receive electronic data. In prior versions to meet this measure, one had to successfully be submitting electronic data on an ongoing basis from a certified EHR. Having witnessed that there is a wide variability in public health capacity across the country, CMS has provided some flexibility here by defining active engagement broadly to include either registering, testing, or transacting. In short, you would get credit even if you're not actively transmitting data, as long as you are on the path and making a good faith effort. For those of you who have continued to struggle with this measure, this would be a very significant change. For 2015 to 2017, there are no changes to the clinical quality measures or CQM. Eligible professionals would continue to report on 9 CQMs, and eligible hospitals would report on 16 from at least 3 domains. In 2015, and for those demonstrating meaningful use for the first time, you would attest to any continuous 90-day in the calendar year through the Meaningful Use Program or electronic report using the established methods. In 2016 and subsequent years, for providers beyond their first year of meaningful use, the reporting period would be 1 full calendar year and can be through the Meaningful Use Program as electronically reported using the established methods. In order to successfully participate in multiple quality improvement programs with a single electronic submission, you will need to collect data and report CQMs for a full calendar year, not just 90 days. Be sure to meet the reporting requirements of all CMS improvement programs. What this means is that you can meet one program requirement under the 90-day reporting period, but fail submission for the Physician Quality Reporting System, referred to as PQRS, or the Inpatient and Outpatient Reporting Program, because 1 year of data is required. Because this is important, I will state it again. The testing for meaningful use, 90 days does not meet the requirement for the Physician Quality Reporting System. You must still report a full year of data to PQRS, even though the quality measures are the same. Please contact us for assistance with both meaningful use and PQRS. The proposed Stage 3 objectives and measures build on Stages 1 and 2 to make the program simpler, reduce burden, and more meaningful. Alignment with other CMS quality reporting programs should decrease confusion between the different programs. Stage 3 is one part of a larger effort across the Department of Health and Human Services to sustain programs which contribute to the delivery of better care, to spending of health care dollars more wisely, and having healthier people and communities. CMS proposed modifications are to help make meaningful use requirements meaningful. Stage 3 also promotes interoperability and health information exchange. Included in the proposed Stage 3 is the option for providers to start Stage 3 in either 2017 or 2018. Stage 3 is proposed to have a single set of objectives and measures and establishes an aligning reporting period for all those eligible to participate based on calendar year. To accomplish these goals, proposed objectives could be removed which are redundant, duplicative, or topped out. In Stage 3, there are 8 advanced uses for eligible professionals and eligible hospitals. There are still exclusions, and thresholds are again increased in the proposal. Stage 3 builds on the groundwork established in Stage 1 and 2, including the goal to increase interoperable health data sharing between all providers of health care. Stage 3 also focuses on the advanced use of EHR technology to promote improved patient outcomes and use of health information exchange. It is an effort to improve efficiency, effectiveness, and flexibility of the program. Stage 3 proposed measures focus on using electronic certified EHR technology to support communication. I've listed all of the 8 objectives in the proposal for your review, but I'm not going to cover each one in this presentation. I will touch upon a couple which I think are significant. Again, I've highlighted some of the significant proposed changes in red. The middle section shows measures for eligible professionals, and on the right section shows those for hospitals. There are proposed new technical, physical, and administrative safeguards required for the protection of health information. The electronic prescribing measure threshold has changed for both eligible professionals and eligible hospitals. For eligible professionals, the requirement is proposed to go from more than 50% to more than 80%, and for eligible hospitals, from more than 10% to more than 25%. Added to this measure is that control measures would be optionally included where allowed by law. You would have to have 5 clinical decision support roles tied to at least 4 clinical quality measures. For CPOE, there are increases in thresholds. It is proposed for CPOE in Stage 3 that entries made by scribes with medical assistant credentials and higher can be included. For patient electronic access to health information, the threshold increases from more than 50% to more than 80%, and there is an additional method to meet this measure. There are 2 measures, and both must be met. Measure 1 is to ensure patients have timely access to the full health record and related important health information. Must be able to access is key here. It means the patient has all the tools they need to gain access to the health information, but does not include the patient actually accessing the information. The additional method to meet this requirement is by using an ONC-certified application programming interface referred to as an API. These APIs are simplified connectors that allow for easier transfer of data. They may be enabled by a provider for the patient to access health information to a third-party application that has more flexibility than current patient portals. The provider would not be required to purchase or implement a patient portal, and supposedly these APIs are much less expensive. The API allows the patient to download their health information to a third party and empowers them to receive information that is most valuable to them. Patients could incorporate all their health information from different sources into a single application For Measure 2, clinically relevant information from a certified EHR must be used to identify patient-specific educational resources, and patients must be provided electronic access to that material. Coordination of care through patient engagement has 3 measures within this objective. You would be required to attest to 3, but only need to meet the thresholds of 2 of them, and you can pick which 2 that you decide that you want to meet. To meet the more than 25% by either the patient viewing, downloading, or transmitting their health information, or by patients accessing their health information through the use of certified APIs. Measure 2 could be met by 2 ways. The secure message can originate with the provider or can be in response to a message sent by a patient. In previous stages, only the message sent by a provider counted in this measure. Measure 3 can include patient self-generated health data or data from a non-clinical setting, including physical therapy, occupational therapy, and home health providers. The inclusion of patient self-generated health data is significant since more and more patients are involved in self-monitoring efforts. Health Information Exchange, or HIE, has 3 measures. Again, you must successfully meet the threshold of 2 of the 3 measures. Improved communication between providers caring for the same patient can help providers make more informed care decisions and coordinate the care provided. Measure 2 now includes transitions of care or referrals in which the recipient provider may already have access to the medical record. It must be using a different billing PIN or tax identification number. The third measure of the HIE objective builds on Stage 1 and 2 medication reconciliation measures. It is renamed Clinical Information Reconciliation with increased thresholds from the prior stages and adds review of the current problem list. You may remember that Stage 1 included having a problem list. Now that function has been taken a step further. The last objective of proposed Stage 3 is public health agencies and clinical data reporting. Language remains, as I explained, for the 2015 and 2017 modified version of Stage 2. Eligible professionals must successfully meet 3 out of the first 5 options, and eligible hospitals must meet 4 of the 6 options. Exclusions claimed for a measure does not count towards the requirement. If you are registering, testing, or transacting, which is moving you towards submitting data on an ongoing basis, that would be considered active engagement and would count towards meeting this measure. The clinical quality measure requirement is not changing, although measures may be retired and new ones added. Part of the alignment CMS is working on is to align how these measures are reported. The goal is to report the data once, electronically, to report for all programs. This is how the proposed timeline for modifications to meaningful use would look for eligible professionals and eligible hospitals. For 2015 only, as a review, you would attest to the modified version of Stage 2 with accommodations for Stage 1. Those in Stage 1 may use alternate exclusions and accommodations. For 2016, everyone would attest to the modified version of Stage 2. For 2017, all would attest to either the modified version of Stage 2 or the full version of Stage 3. And in 2018, everyone would be required to report on Stage 3 measures. They say that Stage 3 is the last stage of meaningful use. That doesn't seem to mean that it's going away. It will continue as Stage 3 with modifications. Here are links to both proposals for these modifications. Hopefully, before you get a chance to read, the final rule will be published. Before I turn the presentation over to Daniel, I want to point out that one of everyone's favorite measures, providing patients with summaries of care, does not show up in these proposals. I turn the presentation back to you, Daniel.
Thank you, Rini, and thank you all for your participation. I know that that meaningful use is a challenging and difficult topic at times, and we're here to help you as much as we can to get through it successfully. What I do want to let you know, like Rini said, Stage 3 and meaningful use are not going away. In fact, they're being incorporated as another proposal into a larger evaluation system, what would be called the merit-based incentive payment system. You noticed in Reni's outline that Stage 3 starts in 2018. So theoretically, everybody is on Stage 3 at the same time in 2018. And, excuse me, in 2019, the MIPS would begin, the Merit-Based Incentive Payment System, and it would evaluate a provider or hospital on 4 areas, one of which includes meaningful use. One is quality, so PQRS would still feed into quality. Resource use, which is the cost of care being provided. And the 4th area is the clinical practice improvement. Clinical practice improvement is another term that many of you may understand as PCMH, or patient-centered medical home. The thing that I like about the new proposed MIPS system is that it allows for larger incentives for those who are participating and doing well. In fact, high performers can get close to a 20% increase in their Medicare reimbursement. And as long as you're participating and doing well, it's close to a 10% increase. And the other piece that I like is that there are smaller disincentives, less than 10% of a disincentive for non-participating providers. So currently, over the next year or two, with the value modifier being added on to PQRS and meaningful use, if a provider or practice is not participating in any of those programs, they have a significantly larger disincentive that would be applied. So with that, we are at the end of our presentation. I just want to wrap it up by saying that I think that there's been a lot of great participation, and I appreciate everybody on the chat box sharing their information about a summary of care and getting direct addresses. We did have a couple of questions come in. I'm going to take one as quick as I can, and then let's see if there's, okay, so there's been, the first one most important question I think everybody always asks when they're in a webinar like this is, where do we get the slides? When do we get the slides? So the slides and the recording will be made available on our website. We expect to have them within about a week or less. And you would go to the Health Insight website and look at the event tab and click on this event, and then they will be available for you there. Also, someone asked a question that said, if a provider sends a summary of care, does that count for the whole clinic? It looks like, so Brooks has been helping me answer these questions, and Brooks' response to everybody says, it looks like they're talking about every individual provider needing to send a summary of care to a provider with another vendor or through the CMS EHR randomizer. So there are some measures which can be accomplished at a clinic or practice or hospital level. We are assuming, and we can let you know for sure, but from our understanding as it is right now, this is a provider measure that's attested individually by each provider. So unfortunately, we're kind of close to the end. We need to wrap up, so I will say that we would love for you to stick around and answer. There will be a survey popping up here shortly. So again, with the slides, we've included our contact information. If you have any questions, you can contact me or Rini directly, or feel free to reach out to whoever your clinic facilitator or hospital contact person is from our organizations directly. And with that, I'm going to just say thank you again so much. Please don't close your browser. We want you to respond to our survey, be brutally honest, tell us how we can make it more effective, tell us what information, if there was things we didn't cover that you wanted to know, we'd love to hear that from you. And again, thank you so much for attending.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.